What's up, AP Psych? Welcome back. So we are just intro to mental disorders and psychotherapies, and now we're going to jump into our first our first category of disorders. And it's a big one. It includes anxiety disorders, obsessive-compulsive disorder and related disorders, trauma and stressor-related disorders such as PTSD. So it's a big one. Just like last video, I would encourage you guys to really take advantage of your reading guides and your extra resources for this unit, because we're going to talk about a lot of different things and a lot of different disorders that include a lot of different symptoms. And we'll do case studies and things in class and mind maps and stuff like that to help you organize them and relate them to one another. But it's a big undertaking, and it's one that we need to put a lot of effort into. So just think about using those extra resources to help yourself organize. So to start, we're going to pick up with anxiety disorders. And it's important to remember that, we're not just learning these things to understand them from an academic standpoint. We also want to understand the human impact that these disorders have. So anxiety disorders are the most common mental disorder in America. They affect 40 million adults ages 18 and over, which is about 18% of the population. Right? And they also impact an estimated 31.9% of adolescents between the ages of 13 and 18. Right? So they're a large portion of the population deals with these different anxiety disorders on a day-to-day basis. So the anxiety disorder general qualities, we're going to talk about 3 specific ones, but overall they tend to include worry, fear, apprehension, intrusive thoughts, physical symptoms, and feelings of tension. And they seem to have like this automatic quality that comes from within the person, kind of like a knee-jerk, uncontrollable reaction, right? It's something that builds up within them, this worry, this fear, this apprehension, and they can't do anything about it, right? It's an automatic thing. So some of these disorders that we'll discuss are generalized anxiety disorder, phobias, and panic disorder. Okay, so those are the 3 that we'll get into a little bit more specifically. So first, GAD, or generalized anxiety, is a prolonged, vague, unexplained, but intense fear, and they do not seem to be attached to a particular object. And that's the key part of GAD. It's unexplained. You don't really know what's causing it. It's just this underlying tension and worry. And studies show that between 4.1 and 6.6% of the population have experienced generalized anxiety. Right? It's more common in women than in men, and it tends to become evident between the late teens and early 20s. But again, the key factor here being this unexplained, unattached fear or anxiety that's developing. And you can't really pinpoint why it's occurring. You just have this general anxiety. So some clinical symptoms here. Excessive anxiety and worrying occurring for at least 6 months. So there's a time frame it needs to occur at least 6 months. Inability to control your worry. You can't get it under control. You can't control your thoughts and feelings. And it's considerable distress or impairment in social, occupational, or other important areas of your life, right? And that gets into those 4 Ds when we talked about dysfunction and distress. It's rising to that dysfunctional where it's impacting your day-to-day life. So in addition to these things, it also has to have the presence of 3 or more of the following symptoms: restlessness, easily fatigued, difficulty concentrating, or your mind goes blank in situations. You might be irritable, experience muscle tension, and have sleep disturbances. So those are the symptoms, at least 3 of those symptoms, as well as some of these features over here to be diagnosed with generalized anxiety disorder. So moving on to panic disorder, the indicators are very similar to GAD, except they are greatly magnified and usually have a sudden onset, right? Generalized anxiety is this underlying, unexplained, just feeling of tension and anxiousness that it lasts for a long time. Panic disorder is like the much more magnified version of this. But again, it's more common among women and younger people. And the clinical features or the symptoms, it's just recurrent, unexpected panic attacks that last 1 month, or persistent concern over having them again. Right? So you might have recurrent, consistent attacks throughout a month, or you may have one really bad panic attack, and then you have this feature where you're extremely afraid and anxious, and it's debilitating because you're afraid you're going to have another one, right? So that could be a part of panic disorder as well. Some symptoms of a panic attack, what you'll notice is it seems very similar to people who've described having a heart attack before. Shortness of breath, dizziness, trembling, shaking, sweating, racing heart, choking, nausea, stomach pain, numbness, tingling, chest pain or discomfort, sense of strangeness. But what you notice about a lot of these symptoms is, they're symptoms of oftentimes very serious and potentially deadly um, conditions. And that's what makes people having a panic attack feel so terrible, right? They often feel like they're losing control or they might actually be dying. And depending on the person, these duration of the attacks and severity, it can vary, right? But at the most severe case, people are afraid of death, like they say. And these can last from, a few minutes to hours at a time. And when you're having a panic attack, your body's in fight or flight mode. There's a lot of stress hormones, cortisol being released, and we know what that can do to your body. So imagine experiencing that for a long period of time and the negative impact that it can have and how debilitating it could be. Next up, we have our phobias. And phobias, we need to make sure, are different than fears. Okay, they're marked by a persistent and irrational, I want to underline that, fear of an object or situation that, again, disrupts your behavior and your daily life, right? It causes distress. People with phobias know exactly what they're afraid of, right? But their fears are out of proportion with reality, and they seem inexplicable and are beyond their own voluntary control. So they know that they have this irrational fear. They shouldn't be as afraid of this thing as they are, but they can't help it, right? It's uncontrollable. It's persistent and irrational. So this chart shows us, the percentage of people surveyed who's afraid of certain things and then who would have phobia of those things. Okay, so people who are afraid of animals, heights, blood, right? Much higher percentages than people who have phobias, right? Because, you might be afraid of spiders, but you don't have a debilitating fear that, maybe you're going to pass out or scream, or you're never going to go into that room again where you saw that spider. Things like that would mark a true phobia. So a few different types of phobias. There's specific phobia, which we talk about for fear of a particular object, such as, object or thing, heights, spiders, dogs, snakes, things like that. And then you have social anxiety disorder, which also used to be called a social phobia. And this is fear and embarrassment in dealing with others, right? You're afraid of interacting with other human beings and that you might embarrass yourself. So you try to avoid those situations. Then we have agoraphobia, which is the fear of entering certain fear-evoking or unfamiliar situations. So a lot of times people mistake agoraphobia for social anxiety disorder. They're not the same. Agoraphobia is not the fear of interacting with other people. It's the fear of experiencing fear, right? You're afraid that when you get into an unfamiliar situation, it might accompany a panic attack. So you avoid crowds, you avoid places where you think your own body might start to experience fear. Right? So that's the big difference between social and agoraphobia. Social anxiety disorder, people are afraid of scrutiny of others and how others may view them and how things may happen when they interact with other people. Agoraphobia is afraid of your own internal cues and how you may internally start to feel fear in certain situations, and you want to avoid that feeling of fear. So it's fear of fear, essentially. Okay, so moving from anxiety disorders onto obsessive-compulsive disorder and its related disorders is our next group. So let's start with OCD. OCD is persistent, unwanted, intrusive thoughts, which are obsessions, and the urge to engage in senseless rituals, compulsions that cause distress. Okay, so when we think about OCD, it's important to differentiate again between everyday people who may be anal retentive or type A or like to have things done the way that they want them to be done, and they're very strict and regimented. A lot of people say, oh, I have OCD about this or I have OCD about that. You need to be very careful in those situations because those people don't have OCD. They're just particular type A people, right? People with obsessive compulsive disorder struggle and cannot physically and mentally function without completing the compulsions that their brain believes they need to complete to relieve their obsessions. Okay, so in the population, people with OCD, 40% of them, their obsessions revolve around dirt, germs, toxins. Others, something terrible is going to happen. Someone's going to die. There's going to be an illness. There's going to be a fire. things like that. And for most people, their compulsions or the repetitive behaviors that they must complete to relieve that distress, those obsessions, is excessive hand washing, bathing, brushing your teeth, grooming, repeating certain rituals. You have to walk in and out of a door a certain number of times. You have to flip the light switch on and off a certain number of times. Checking doors, locks, appliances, car brakes, homework. Okay, so someone with OCD may believe that if they don't flip the light switch on and off 20 times before they leave a room, that their son is going to die as a result of that. They know that doesn't necessarily make sense and it's not rational, but that intrusive thought is so linked in their brain. There's a neurological connection to their compulsions, and it makes them feel better, and they have to do it to relieve those obsessions and to get those intrusive thoughts and unwanted thoughts to go away. So just going back over the cycle of OCD, you have obsession, right? That intrusive thought that you cannot get to go away from your mind, which causes you unnecessary and a large amount of anxiety or stress, right? And this is where it becomes dysfunctional or distressful or deviant. And so you have to complete this compulsive ritual in order to relieve that anxiety or stress. That provides you with relief, right? This is how the system is reinforced, right? When we talk about learning and how learning theorists would describe, the way that OCD and anxiety and phobias are reinforced, it's because you're relieving that anxiety or stress through the compulsive rituals that you are performing. And it's not like you're getting some rush of dopamine or something like that. The relief and the reinforcement comes from getting rid of the anxiety and stress in that particular situation. So when we do brain scans of people with OCD, you can see high metabolic activity, this PET scan, in the frontal lobe, right? And that's the area involved with directing attention, right? And so we know that people who are experiencing OCD episodes and trying to relieve their compulsions and relieve their obsessions, there's a lot of activity in that frontal lobe and that decision-making and processing area of our brain that shows that they're overactive in that situation. And that's part of what's happening with people who are experiencing OCD. Now, so a few OCD-related disorders. Now, some of these used to be categorized as what we call somatic symptom disorders. And with the update of the DSM-5, they've been moved to OCD-related disorders, right? So things like body dysmorphic, trichotillomania, and excoriation disorder used to all be part of the somatic symptom disorder, because somatic means of the body, and these are things that have to deal with your body. However, they've now been changed to the OCD-related disorders because they deal with some type of improper thought and some type of obsession that you're experiencing. That's hard to overcome. So body dysmorphic is a preoccupation with an imagined or exaggerated defect in your personal appearance. We're going to get into this one a little bit more specifically on the next couple slides. Then you have hoarding disorder, persistent difficulty in discarding or parting with possessions because of a perceived need to save them, and distress arises when you're asked to get rid of those things. You can't overcome that thought or that obsession. Trichotillomania is a hair pulling disorder, which involves recurrent, irresistible urges to pull out your hair from your scalp, eyebrows, or other areas of your body despite trying to stop. That's that obsession and compulsion kind of idea, similar to OCD. And then you have the skin picking disorder known as excoriation disorder, repeated picking at one's skin, which results in skin lesions causing significant disruption in your life. Okay, and that's just another reminder of the 4Ds that we talked about. There has to be has to be a deviant behavior, dysfunction, distressful, and potentially dangerous, right, to rise to the level of a mental disorder. Okay. So to look a little bit closer into body dysmorphic disorder, this BDD preoccupation is time consuming, right? Often you're thinking about the size or the shape of facial features, acne spots on your skin, wrinkles, thinning hair, and scars, and you're obsessive about it, right? These individuals experience marked distress over their supposed deformity. And these feelings of self-consciousness about their defect may lead to the avoidance of work, avoidance of public situations, self-isolation, things like that. And as a result, these people experience higher rates of major depression and even suicidal tendencies. BDD typically becomes evident in adolescence, and it affects males and females equally. which is something that misconception that many people have, is that it impacts females more often. That's not the case. It's not true. It impacts males and females equally. So when we look at some examples of what individuals with BDD see when they look in the mirror. So here we have two self-portraits that were drawn in therapy. These women were asked to draw themselves as they saw themselves, and you can see the emphasis that they place on things like their ears, a long nose, or this woman believes she has, an extremely long chin. And while most of those things are untrue, that's what these people see when they look in the mirror, these exaggerated self-image, that they can only focus on these parts that they dislike about themselves. There's a lot of evidence to suggest, and many experts also think, that Michael Jackson himself suffered from BDD, and you can see that through the changes he put himself through as he got older and older throughout his life. So, moving on to our final category of trauma and stress-related disorders. And we'll start with PTSD, or post-traumatic stress. And this is something that lasts for 4 weeks, 4 or more weeks of the following symptoms, which constitute post-traumatic stress disorder. So we'll see some symptoms here. Again, another misconception, not necessarily a misconception, but one that people focus on when they hear PTSD is they think of soldiers a lot, right? Which is very true. Many soldiers do experience PTSD because of the things that they see on the front lines and the things that they experience. But anyone who experiences some type of traumatic or overly stressful event can experience post-traumatic stress disorder, right? It's not just exclusive to one group of people. So many of these people experience haunting memories, right? Nightmares and flashbacks. And as a result, they withdraw from society. They have this jumpy anxiety because of the things that remind them of their stress, and oftentimes have sleep problems because these haunting memories and nightmares and flashbacks happen while they're sleeping. Only about 10% of women and 20% of men react to traumatic situations and develop PTSD, which is a relatively lower portion of the population when you think of experiencing a severely traumatic event. Not necessarily a large group of those people develop PTSD. And Holocaust survivors have shown remarkable resilience against traumatic situations. So it just raises the question of, what's behind, why do some people develop this PTSD and others don't when they experience the same situations? There's many different theories behind that. A lot of them come back to brain chemistry. And in those regards, and in addition, all major religions of the world suggest surviving a traumatic event leads to the growth of the individual. So, even if you experience some type of stressful and traumatic event in your life, which many people do, it doesn't mean that you're going to develop PTSD. So our other traumatic and stress-related disorder is acute stress. It's very similar to PTSD, but it starts immediately after the trauma, whereas PTSD, there might be a little bit of a gap before you start experiencing those symptoms, and lasts anywhere from 3 days to 1 month, right? Any longer, and it would have to be diagnosed as PTSD, right? Long-term. Acute meaning much shorter term. Now, these were previously considered anxiety disorders, right? Which I mentioned earlier, but they're now their own category, as these patients do not always experience anxiety. Rather, sometimes they experience anger, aggression, dissociation, right? So they move them from the anxiety category into their own trauma and stress-related disorders because of that. So we're going to talk about a couple of the perspectives that try to describe, where anxiety and OCD and trauma and stress-related disorders originate from. And first, the learning perspective, those theorists suggest that fear conditioning leads to anxiety, right? This anxiety then gets associated with other objects or events, which we've talked about before with conditioning is stimulus generalization, and then gets reinforced, right? So it's this reinforcement of fear conditioning. You've been in a certain situation where you've associated fear with that situation, and then you generalize it to others that are similar. Other fear responses, investigators believe, are indicated through observational learning, right? Young monkeys develop fear when they watch other monkeys fear snakes, right? So we, as people, may learn to fear certain things in certain situations because we see other people are afraid of those things as well. From the biological perspective, Natural selection has led our ancestors to fear snakes, spiders, and other animals. So that fear preserves the species. Maybe that's part of our natural fears that we have. Also, twin studies suggest that our genes may be partly responsible for developing fears and anxieties. They've shown that identical twins are more likely to share phobias than fraternal twins. Right? So there may be some genetic component to these anxiety and other disorders that we're developing. And finally, GAD, panic attacks, and even OCD are linked with the brain circuitry in our neurology, such as places like the anterior cingulate cortex in the frontal lobe lights up when you're experiencing generalized anxiety, a panic attack, and OCD. They all have this common area of the frontal lobe that experiences increased activity. So that could also be another reason for another more area for more research when we discuss why these things are happening. So that kind of wraps up our intro to anxiety, OCD and related disorders, and trauma and stress related disorders. Again, take your time, go back through, use your reading guide to supplement with symptoms and things like that. And in class, we will do a bunch of different case studies. We'll make some maps and things to make sure you feel good about these things. And we'll move on to our next category in the next video. Let me know if you have any questions.